to get cracking with a really great program for the next couple of hours. So the next presentation is on the Doing It Together project, which will be delivered by Dr. Michelle Scerri and Waylon Murphy. So Michelle is a GP based in Katherine who recently started working as a clinical project coordinator in our youth diabetes team. Michelle had previously been working for Wellingong Health Service in child health for many, many years, where she witnessed a worrying increase in type 2 diabetes among clients and was really curious about whether there could be better ways to support their care. Waylon Murphy has been part of the peer support group at Worley for a number of years as well, and is now employed in our team at Menzies as a peer facilitator based in Katherine. So I'd like to welcome you both up here. Thanks.
Good morning. So my name is Michelle Scerri, as Renee said, and I'm from Katherine. And today I have Waylon Murphy with me. We would like to pay our respects to the Larrakia people on whose land we meet and to their elders past, present and emerging. Waylon and I are in agreement that this is scarier than any ride at the show, but we have also agreed that we're not going to scream, swear, spew or run off, right? Yeah, so we're buckling in. All right.
We are going to tell the story. We're going to tell the story together. This is what we hope you understand about this project by the end of our talk. Why is it important? How this work has changed and changed us, and what we have learned so far.
As we've already heard this morning, so youth type 2 diabetes refers to type 2 diabetes with onset before 25 years of age. First Nations people in the NT are experiencing the highest rates of type 2 diabetes in the world. And this has significant implications for this generation, of course, with reduced quality of life and complications that can reduce life expectancy, but it's also going to impact the next generation. The story of Doing It Together is one that started 6 or 7 years ago. I was working at Wellingong Health Service in Katherine at the time, and we recognised a rapid growth in the number of young people being diagnosed with type 2 diabetes. We felt really unsettled, not just because of the numbers, but because we found it really hard to see how young people with a chronic disease like diabetes could fit within our existing health structures. At this time, I really didn't have a good understanding of youth type 2 diabetes, nor did my colleagues, or really anyone in our community. The management was really challenging. I didn't feel like I had the knowledge or skills I needed. I was worried about what I was seeing. I was frustrated about kind of waiting around in my consult room for young people to just walk through the door and talk about their diabetes. And then when they did come in, the consultations could be really difficult. It was difficult to establish rapport. Young people were not always ready to hear about diabetes. Many were struggling with mental health problems. And I just found there were just too many barriers to managing diabetes. I thought that I couldn't really achieve anything much in a consultation, and I felt really overwhelmed by the size of the problem. So I'm just going to ask Waylon, what were things like for you back then at the same time?
It was stressing and annoying, stressing. I didn't care about diabetes at first. Never actually focused on it. Thought I had no diabetes. What else? Then I started feeling weak from there.
So I guess we figured out that we needed to find a better way. And I like this photo, particularly on this slide, because this is in one of our peer support groups, and we're putting up this stupid badminton net that took at least 4 or 5 people to put up and usually fell down next minute. But it taught us a lot about teamwork and problem solving. Sometimes we even got a game, didn't we, in the end?
Yeah.
We worked hard enough.
A lot.
So at Worley, we started trying some new strategies. We tried a dedicated youth diabetes clinic time to make it a safe space for people to come to get their clinical care. We tried an outreach run where we supported medication access and just engagement of people that we weren't seeing. We tried to work with schools on ways that they could also support young people who are attending. And we tried to develop more specific youth-orientated care plans that engaged young people during their consultations more. And we set up a peer support group. And of all the things that we tried, we felt the peer support group stood out as the most successful strategy. The role of the peer support group was just to build connections and to try and break down some of the stigma, shame and isolation that we saw young people with diabetes dealing with. It was just designed to be a safe space that was mostly just fun and supportive and occasionally a little bit educational too. So Waylon, I was wondering if you can remember like the first couple of groups that you came along to and what they were like. Can you tell people what it felt like those first couple of times? Yeah.
It was really shamed at first. Ever since my mom dragged me into the group.
She did too.
Yeah. Didn't know much people.
Mm-hmm.
Yep. Ever since I started going, my mom always dragged me into this. But I still love her. Anyway.
Lucky.
Yeah. But anyway, yeah.
And can you tell us a bit about what usually happened in the groups, what we did? Because most people haven't been to this peer support group, so just tell them what we do.
We've done a lot of activity lately. What I mean by that, we just sit down and just do any activity, like, for example, painting, doing board games. And as soon as we started playing games and stuff like that, my sister, and a niece of mine who works at thing now. Oh, sorry, I skipped that part. Sorry. We just sit down, play board games, and we started talking about diabetes and stuff like that. Like we just asked them how they're feeling about having diabetes on their own. But yeah.
So there were some challenges in keeping the peer support group operating. The staffing and logistics were difficult because it clearly wasn't a core service of the health service. We found the broad age range. We had children from 8 and then adolescents up to the age of 16 or 17, and this created challenges with differing social needs and engagement, and just how we could keep a cohesion, the group quite cohesion of the group. Don't run away. And despite our efforts, we actually found it really hard to engage families to be part of the group, which was what we'd hoped in the beginning.
Yeah.
Very good. Yeah. Although we didn't have any formal evaluation at that early stage, and we felt like we were only really just managing to keep going with fluctuating numbers, we were starting to recognise some really subtle signs of change and of success. So firstly, young people kept turning up, which made us think that we had created a safe space that they valued. We kept turning up, which built trust over time. As the connections grew, we found that everything became easier. There were more smiles, which suggested there were some improvements in well-being. There was less shame, as Waylon talked about, and we could talk more easily to each other. We felt like there was an improvement in how young people were able to access their care, which came in all different sorts of things. I can still remember for one young person the first time that they actually used my name, and even though that sounds like a really tiny thing in the scheme of it, that's a real barrier to care. But once they knew my name and were happy to then ask my name, then the next step was asking for medications. I haven't got any medications, can I come and get some? We noticed also that this growing trust that we were building was also transferable to other health professionals. So people that weren't necessarily involved in the peer support group, but it made it easier for young people to attend early, even if they were seeing somebody else. Or we got a bit of an uptick in our attendance at the specialist clinic days. And I think, you know, we probably started to learn a little bit more about managing diabetes. I think the changes we're experiencing were two ways, and we certainly as health professionals, we started to become much more aware. We started to understand what the world looked like from the point of view of young people. And so we were better able to anticipate what the barriers to care were and have better insight into what we needed to change in order to create a better service. But most excitingly of all, we felt this tug of young people wanting to take control of the reins, which started out with people battling over who gets to DJ on the way home in the bus. But my favourite milestone moment was when Waylon gave Jamie, who's our diabetes educator and the co-founder of this group, gave Jamie and I a complete dressing down and said, if you want us to keep coming, you are going to need to make this more fun. And he was telling us that he could do it better. And it was music to our ears. So, Waylon, do you want to add anything about anything that you saw changing over time in the group from when we were in that early day and everyone was a bit shamed and didn't want to talk? Is there anything you want to talk about that? No? Okay. Pass? That's a pass?
Yeah, that's a pass.
Okay. We agreed we can have passes. We were already partnering with Menzies on a number of diabetes-related projects, and now we recognised that we had an opportunity to really harness that emerging peer leadership and develop it into something meaningful that could hopefully provide a really unique support structure for young people. A peer education program was co-designed with a plan that we would employ peer facilitators, provide education and training, and then enable them to then go on and provide the peer support and education. So two slightly different things. And the ultimate goals were obviously to improve self-management and understanding of diabetes, but well-being as well, and hopefully in the very long term to improve some outcomes. So additional funding was sought from Menzies in partnership with some of the communities and organisations in the Big Rivers region that stretches right around Katherine, and the Doing It Together project was born, allowing us to hopefully build on some of that existing work. So, Waylon, this is not past this one. Can you tell us what you do as a peer educator or peer facilitator?
So I'm just gonna say me and my team.
Yeah, good.
Okay. Well, yeah. Anyway, we go out in different communities, which is, well, just two actually. Yeah, but we're getting there. We go out to Kalkarinji, Baralula. That's the only two things. But anyway, sorry. Yeah, sometime. Anyway. Yeah, so we just go out in communities, talk to young kids about diabetes, you know, just to make them understand how diabetes actually really works. You know, for example, I told one of the kids in, I think Baralula, yeah, Baralula, about the diabetes that they have. It can cause anything. Well, as I explained it, they started to understand about diabetes, and over the past few months, I guess, they started realizing about diabetes. So we ended up going back and forward, Baralula, Kalkarinji.
So that's what you do as a peer educator?
Yeah.
Awesome. This is your line. Because it's one line.
Okay. This is most of our team. Avoid my face. Okay. Yeah.
Yep. Good. Well done. Yeah, but listen, this one's an easy one. So can you tell us what you do in one of your, so this is one of our peer education sessions that you might run at Borroloola or Kalkarindji. Do you want to tell us what you do in that?
So like I mentioned before about activities, we have a feltman. During our session, we bring out a feltman, so that way we can explain it just beside talking about diabetes. So we use the feltman and tell mainly young kids with diabetes how diabetes, insulin, and other things that will help the body. And as we use the feltman as a, how can I put that? Yeah, something like that. Yeah. We ask them, well, they ask us question, and then we just give them an answer. And yeah, pretty much.
Yeah. Okay. So Waylon's already touched on quite a bit of this, but so the Doing It Together project then is a combination of peer support that's been provided at two sites, Kalkarindji and Borroloola. This was preceded by a period of co-design work where you went out and you talked to the community about what they thought would work in the community. Yep. And then they've been out there delivering. So they've had 10 visits to Kalkarindji, and they've just started to, it was mainly around peer support, but because community sort of requested it, they've moved a little bit into providing these education sessions as well. And a similar story at Borroloola, with the slight difference that out there are some community liaison officers who were employed out there who work in the trade centre and provide services, and now and work alongside the peer facilitators to provide support and a bit of education as well. Okay, keep going. Okay, so some of the challenges that we see with providing peer education is that it's really resource intensive. We're often, when we're working with peer facilitators who are in their very first employment role, there's a lot of support required to help them be job ready. Obviously, anyone who travels remote knows that it's resource intensive to travel to remote communities. We know that for our peer facilitators, they're managing their own type 2 diabetes as well, and often we find that health priorities will impact on program delivery or the work that they can attend. And at times, and of course, at times there's also other family, educational and social priorities that come up. At the moment, there's ongoing funding until the end of December, but obviously a challenge of supporting long-term a project like this will always be funding. Okay, you ready to talk about camps?
Okay.
Yeah. So Menzies was able to get some extra funding to plan some camps for this year. This was something that arose from the co-design process where Waylon thinks it's his own idea. No? No. But it wasn't just him. Lots of people thought it would be a really good idea to have some camps. Yeah. We should call them the Waylon Murphy camps. Okay. Okay. Do you want to talk a bit do you want to talk a little bit about the camps? Tell us. Yep. Okay. Oh, talk about what we did on our camp, you know, the one from May. Do you want to talk about that? I'll go to this slide. What were the things we did?
So can you see this? Yeah. Okay. So we have a men camp coming up in 2 weeks time. So we have a guy named Adam Drake. He's the one who's working with us. So we organize bus transport and other things that kids that has diabetes that will come to our camp, mainly, yeah, young kids with diabetes. So I would say it's all about having fun and focusing on diabetes, explaining how sugar actually works inside our body. Yeah, it's just that we don't want to put so many pressure in mainly young kids that has diabetes. Yeah, so I would say it's all about having fun.
Yeah, We might just need Anthony's help now. We've got that was talking about fun. So we had a training camp back in May, and we've got the young men's camp coming up in August, and we ran a young women's camp in May as well, which was led by the peer facilitators and the wellbeing officers. Sorry, I'll just go, just before we move on, we'll just show you a short video about the camp. Yep.
Yeah.
Hi, nice to meet you, Dr. Boston.
I believe the purpose of this diabetes camp is to have awareness for these young women on their diabetes and be able to accept it and work on ways to have a better understanding of diabetes.
Lots of tomato plants. We've got about 30 different tomato plants. And what we found is... I'm Edwina. I'm one of the peer facilitator for Menzies, based in Castrum. I work with Menzies I teach about what is diabetes. It's like they're looking for someone to encourage them. Someone that can pull them out from what are they hiding from? Like they have somebody behind their back, like watching them. Like we're here to help. Talk to us like we're their friends. They get very, very comfortable now. Yeah, they just took out the shame out of themselves.
Throughout this camp, I really hope they have more of an acceptance and don't get too shame job about it and able to stand up for themselves and their voice.
My favorite part at the camp was the balloon game yesterday and the kangaroo tail last night, and when we went to the Catherine Gorge.
Encourage them more to come and tell them it's like really fun, you know. Yeah. Get to learn more things about like the countryside. Get to know other girls, you know, from other communities and more, you know, leaders, Darwin or in town.
Other communities, like girls come from other communities, we can show them, they can show us, learn us their things and what they do, and we can do the same to them.
It's been really, really good. Like I'm enjoying every bit of it. Yeah. I reckon us laughing, you know, telling stories about each other's life. It's making me think a lot about what I need to eat more of and less of. They need to know they're not the only ones that going through what they're going through. And don't be ashamed. Don't be ashamed, you know, there's a lot of, you'll make a lot of friends and you might learn more about diabetes. I think I would just say fun, really, it's really fun coming with all the girls, seeing them smile, but yeah, fun.
Can I still move on, Anthony? Okay, just not letting me move on. Oh, okay, yep. Okay, so I'm going to have to go a little bit fast, but we really wanted to talk to you about some of the preliminary findings from this project. So obviously data collection is not yet complete, but importantly, a developmental evaluation approach has been used to guide this project. So this allows reflective practice to adapt the intervention to the context. So it supports trying something, watching what emerges, seeing whether it works, are you learning from it, and then allowing you to change what you were doing if you find it's not working. And in my head, I had to understand this, that it's different to some other research methods where you might apply a protocol to the very end of the study and then stop and look back to see whether it worked or not. So as you can imagine, in this type of work, we had lots of instances where we changed what we were doing throughout to make things work, where we were coming up against barriers. I think one good example was that in the initial project, the idea was to employ some CLOs out at Kalkarinji, for example, and this was really difficult. Employment in the remote community was really difficult, but these peer facilitators were stepping up and they had more capacity, so they were the ones that ended up going out there and providing the peer support groups and the peer support education. And I think this inbuilt flexibility has really allowed us to kind of troubleshoot along the way, respond to community needs, and then hopefully build a project that's even more fit for purpose. So I won't go through these in detail, but these are some of the enablers and challenges so far. In some ways, it's sort of not rocket science and probably what you'd expect, but I think, you know, it really highlights the fact that, you know, youth leadership is at the core of it. Peer leadership is at the core of it. Young people are going to listen to other young people that they really relate to. The relationships and the people that you're working with is critical, and being consistent, continuing to show up and continuing to work towards something is really important. And I think in terms of the challenges, we've been through some of them, but I think in terms of community readiness and prioritisation, I think that's a really critical one where not every single community is in a position where they can embrace something like this, or it's not necessarily always the priority right then. And so for some communities, there might be a benefit in having a longer lead-in time where you're building some relationship and awareness and that sort of thing before trying to implement a project like this. But unfortunately, you know, with tight timelines around project funding and that sort of thing, that might not be quite possible. That's a limitation. And I'll just go really quickly through because I've probably missed my, yeah. Okay, so I'll just flick through. These are some of the emerging themes that we saw, and I'll just flick through some of the quotes that have come out of it. But certainly what we've hopefully alluded to in terms of engaging and connecting and empowering young people. Waylon saying stop. You don't get to say stop, they get to say stop. And the strength and growth of peer facilitators, which, you know, hopefully is also kind of evident. And hopefully once all this work is complete, you know, you'll be able to see a lot more of this in detail. We've been through some of the flexible nature of it and providing education that's in the right place and in the right way, which Waylon talked about a bit with Feltman, and being in a context that in a space that youth feel safe in. And then, you know, peer support groups are starting to become part of a referral process. So, you know, we hope that this eventually will start to be something that's embedded as part of the care for young people with diabetes. Implementation is going to continue until September, and then there'll be a period of evaluation up until December. And then I guess there's one application in, as Renee alluded to, looking to extend this work beyond that, and possibly a need for some further applications as well, submissions as well. There we go. I think that's it. Yep. Did we make it? Yeah, we did.
Thank you both so much. We don't have any time for questions right now. I'm really sorry. But if anyone does have questions online, if you just pop them in the chat box, we can do our very best to maybe get back to you. Otherwise, you can always make contact with us in the partnership or with Michelle and Waylon. Next up, I would love to introduce Dr. Diana MacKay and Norlisha Bartlett. So Diana is a deputy co-lead of our partnership and also an endocrinologist and clinical lead of diabetes at the Royal Darwin and Palmerston Hospitals. And Norlisha is a Bardi and Jabba Jabba woman from the Kimberley. She has over 10 years experience working in remote communities across the Northern Territory and Western Australia. And she's been working here with us in the partnership for over 6 years. So welcome, guys.
Thanks, Renee. It's a real pleasure to be able to share about this project. I know we've spoken about this project in this forum in previous years, but it was really just getting off the ground, and it's exciting today to have the opportunity to actually share what the team has been doing. And Norlisha will really go into detail with that perspective of the work on the ground. So I won't spend a lot of time on this. Brandy spoke very eloquently about this already this morning, but really just to highlight that this intergenerational cycle of diabetes contributing to the epidemic of type 2 diabetes that we're seeing in communities is really that rationale for why we are doing this project. So this diabetes in pregnancy co-design study aimed to co-design a multi-component intervention to reduce diabetes-related risks before, during and after pregnancy among Aboriginal and Torres Strait Islander women and families. And this study has 3 phases. So the first part, Part A, was qualitative research where we were really listening to the voices of Aboriginal and Torres Strait Islander women, as well as their families and health professionals about those experiences of diabetes in pregnancy. In Part B, we took what we learnt from that qualitative research back to communities again and went through predominantly a workshopping phase to work out the priorities in each community and actions that could be taken, with leading then on to Part C, which was implementation and evaluation. And through, I guess, the whole process, or particularly through the co-design process, that's been underpinned by a co-design methodology using experience-based co-design, which really places the importance on the voices of people with the lived experience, as we've heard so much about already this morning. And you can see our model there with women at the centre, surrounded by the community and services that we know support them. And for us, it was really important that we were incorporating founding principles of First Nations research, as you can see there across the bottom. And we've been lucky to have an amazing team across the 3 regions where we've been doing this study, working in collaboration with our health service partners. So that's been Malala in Maningrida in the top end, Central Australian Aboriginal Congress in Alice Springs, and the Cairns Diabetes Centre and Mulungu in Far North Queensland. So to briefly talk about this qualitative research in the first part of the study, this was really a collection of 3 pieces of qualitative research, with the first one looking at women's experiences and their understandings about diabetes. The second one exploring women's preferences for a program to reduce diabetes-related risks after their pregnancy. And the third one delving deeper into the supports that were important for women. And to just highlight, I guess, one key finding from each of those studies. So in the first one, it became clear that women did know things about diabetes in pregnancy, but for, I guess, a whole host of reasons, that knowledge was sometimes superficial, and we really need to improve how we communicate about diabetes. In the second study, it was clear that rather than a focus on medications, interestingly, as was discussed this morning, women really wanted a healthy lifestyle program, and programs needed to be culturally safe and appropriate to their local setting. And in the third study, women and the other participants told us that family and health services were important supports for women, but there were lots of barriers to them being able to really use these supports as much as possible. So all of these findings led on to this Part B, which, as I said, was predominantly based on workshops with each of our collaborating services, involving women, particularly of childbearing age, community members and health professionals. But the workshop data was also supplemented by individual interviews and various meetings with stakeholders. And so the outcomes of that process, the priorities that were identified in the Northern Territory are shown in this figure, which was published last year. And you can see the key priorities really aligned between Central Australia and top end, and I'm sure won't be a surprise to anybody, but it's great to have these articulated. And they were around access to healthy foods and physical activity, the importance of traditional practices and being able to connect to culture, improving communication relating to diabetes and related risks, the prevalence of stigma then causing silence and denial related to diabetes. And as we all know, women living in community have a lot of other things going on that are priorities for them, making it potentially difficult for them to engage in things to improve their own health. Then in Far North Queensland, the participants really honed in on 2 key priority areas, particularly relating to gaining skills and knowledge in meal planning and cooking. And interestingly, in Queensland, where this work was done slightly later time frame than in the NT, there was an emphasis also on being able to do this while keeping to a budget, which I guess is interesting given in the broader scheme in Australia at the moment, we know a lot about cost of living issues. And then the other key issue in Far North Queensland was also relating to diabetes knowledge, so aligning well with the Northern Territory. So if I move on to then implementation. So in Central Australia, participants identified that they wanted to have a support group as a safe place where women could come together, learn and really make those cultural connections as well. And very conveniently, it became clear that Congress already had a weekly women's group, their Women Together group, which we were then able to collaborate with and hopefully enhance by adding into their existing program monthly education sessions based on topics that were specifically identified by the women during that co-design phase. And importantly, these sessions were facilitated by an Aboriginal woman. And then we would bring in, I suppose, guest experts such as midwives. The other key element in the Central Australia was that the team facilitated several family days throughout the year, which were really important in terms of health promotion. Okay, Norlisha is going to talk really in detail about what happened at our, has happened at our top end site, and where we're working with Malala. But together they established the Mani and Karira Healthy Women's Project. And I'll just mention the 3 key areas that this project we're working in. So one was providing, again, health education in a group setting. Then there was physical activity, so that regular pool activities, and working together with key stakeholders in the community around improving the options for healthy food in stores. And in Far North Queensland, because of those differences in terms of the timeline for the study, we're actually just starting implementation now, having had ethics approval in the last couple of weeks. But the key focus areas are on increasing workforce capacity. So part of that will involve delivering the Feltman facilitator training, as well as various other upskilling events for health service staff. And then again, family-based education sessions. I guess with the difference in Far North Queensland being that they really wanted an emphasis on family education as opposed to education for women. So the evaluation, which we are collecting data for at the moment, and we'll be looking forward to reporting on hopefully in a future symposium. So we'll be looking at the impact of the program on women, and while we'll be looking at sort of traditional health indicators, I know we've spoken this morning about it being so important to look also at cultural connectedness, as well as we'll be interested to know in whether women are engaging more with services. Then we'll be looking at the impact on the health workforce, as well as on the communities more generally in terms of it being health promoting environments. We'll be really interested in how the program has been implemented, and I think Norlisha will talk about some of that already from her experiences. And then, so crucially, the acceptability and sustainability of the program. And I'll hand over to Norlisha now.
Yeah, so as mentioned, my name's Norlisha Bartlett. I'm a proud Bardi Jabba Jabba woman born and bred in Broome in the West Kimberley. I've been a part of the partnership for 6 years, 4 of which I was lucky enough to be Louise Maple Brown's EA, and I learnt a lot from her, and have now started in this project. I wanted to acknowledge the Larrakia people as traditional owners of the land in which we meet today. I want to acknowledge the lands in which this project was based, so that's the Cooney people in Maningrida. I respect all elders past, present and emerging, and I pay that respect to other Aboriginal and Torres Strait Islander people in the room. So a little bit about the project Diana's gone into. Maningrida is one of the largest remote communities in the Northern Territory. It's located in East Arnhem Land. It has 3,000 people, as well as more than 30 outstations and homelands. There's about 15 languages spoken in Maningrida, including Jabana, Brada, and Kunikiju. So as Menzies School of Health Research, we were able to collaborate with Malala Aboriginal Health Service on the Diabetes and Pregnancy Co-Design Study. So the women in Maningrida really took charge of this project from the very beginning by designing and leading a project that looked at their holistic health, including health education and promotion. I just want to point out here that all the women in Maningrida, as with other Aboriginal and Torres Strait Islander women, were so strong, so resilient. They care and are passionate about their own health, and they just felt that they never had a safe space to speak in. So through this project, we were enabled to create a safe space for the women to come together and share their health stories and journey. So this was done in true partnership with the broader community, and the health professionals, and then that's the name came to be born, the Maningrida Healthy Women's Project. So through this project, we were able to weave traditional knowledge with modern healthcare. We focused on preventing chronic conditions such as diabetes, enhancing overall well-being, and cultivating a route path to true health empowerment. So working with Malala Health Service for 45 years, they were a government-run, and in 2021, Malala became a community-controlled clinic. So this was a really important moment for Maningrida community because it allowed the community to take charge of their own health. And as a result of this, the Women's Cultural Hub branched out, as you can see this picture here. On their own, they created a safe space centered on women's priorities, including health. So this is a picture of the Women's Cultural Support Hub workers, each of them representing the main language groups in the community. And that was just to ensure that each family voices are represented. So we've been over why it's so crucial that work in diabetes needs to be done, and also why important strategies are developed to address and prevent diabetes epidemic affecting Aboriginal and Torres Strait Islander women. So Jessie Phillips, who was pictured previously in that, captured the gravity of the situation when she said that this isn't a joke anymore. She made this powerful statement after seeing the stats on chronic disease in the community, numbers that weren't just data points, but lives. The extent of this crisis was confronting. Chronic conditions were not only widespread, but they were leading to the preventable deaths of community members, grandparents, parents, aunties and uncles, siblings, and their offspring. So during the last dry season, to give you context, even though it's a beautiful season for us in many remote communities, it's the funeral season. Maningrida had 22 communities over several months. So this moment was a turning point for her, and she wanted the community to understand the gravity of the situation. As mentioned previously, this mind map illustrates the numerous responsibilities that women juggle. They face so many competing demands that significantly impact on their health. One woman said that community life was like a river. You are constantly jumping in and out of it, going to school, to the work, or the clinic. But when you jump back in that river, it takes you down the stream until you jump back out again. So through these numerous workshops, the women and the community were able to identify the 3 main priority areas. So that was enhancing health education, and we were able to do this through story sharing sessions where clinicians were invited from the clinic to come outside to a safe space and educate women. So there were topics that ranged from healthy skin, healthy eating, checking sugars. We promoted wellness through physical activity, and we were able to introduce a water fun session with the physio, both in and out of the pool. And the last one is supporting better access to healthy foods. So we were able to work with the local stores, and that work is still ongoing. So Aboriginal and Torres Strait Islander leadership was not just important, but it was essential to the success of this project. From the very beginning, the research design was led by experienced Aboriginal and Torres Strait Islander researchers. As mentioned earlier, this was developed in close collaboration with Malala Health Service and aligned with the vision of the Malala Women's Cultural Hub. Our on-the-ground team was also co-led by Aboriginal women. I was able to work as their project officer alongside Shana Phillips, a local Maningrida woman who worked as a research assistant. Together, Jessie and I co-chaired the Maningrida Healthy Women Project Advisory Group. So that was to ensure that women's feedback was given and that open communication with community and service and stakeholders so that the women's voices and feedback was heard but also acted on. This leadership was truly the foundation of creating a safe and cultural space for women. And that's shown in the fact that over 140 women participated in the project's implementation activities, which is a true testament. Another important component of the implementation process was that ensuring meaningful community engagement. So we were able to build trust and visibility in the community, and that meant by giving back in a meaningful way, which means that we had to be deeply involved in community life. For us, that meant showing up. It meant going to community events, and not as an add-on, but it was central to how we worked. We supported local events that they were doing throughout the community during the year, including festivals, health promotion activities, and in-time kind support to Malala Health Service for their health drives. So these weren't just opportunities to promote the project, but they were really about strengthening relationships, being present, and showing up, not just for the research. So just quickly, implementation activities that were conducted throughout the year, health education through our story sharing sessions, physical activity, 14 sessions, and community engagement. Of course, like many research projects, there came with a fair share of challenges. One major challenge was navigating cross-cultural health communication, especially with the 15 different dialects in Maningrida. So we had to be clear and respectful with the communication, and this required ongoing effort, flexibility, and support from local language speakers. Another significant challenge was maintaining focus on the women's health amidst other competing priorities. Life in community is so dynamic, but there were times when attendance at sessions similar to Catherine and everywhere else just depended on what was happening in the community. So this reminded us that we had to be adaptable, we had to listen, and we had to continue meeting women where they were at while still trying to stick to project deadlines, which Tara kept reminding me of. So next steps, this project is currently being evaluated from June to September. Feedback will be presented to Malala Health Service, and funding is being applied for to sustain this project into the next phase. So I just quickly want to acknowledge the women, the families, the community members who have participated in this work, and also to everyone else involved. And a special thank you, my husband is here today. I spent 2 years away going to community, so thank you for having the families back while I was away. Thank you.
Thank you both so much. That was another really beautiful demonstration, I think, of work that's been deeply embedded within community and listening to community priorities, and then being able to pivot the project to meet those needs. And Michelle and Waylon, you guys both demonstrated that beautifully as well, although yours was more of a whirly up process, which is a slightly different approach, and I think both have got absolute merit. So thank you. We have a couple of minutes for questions. I might take one firstly, if I can, for Diana and Norlisha, and then if we have time, we might go back to see if there was anything for Michelle and Waylon, who seems to have disappeared. Does anyone have a question for Diana or Norlisha? Are there any online? No. Everyone's just flabbergasted at the great work. Jen. Oh, we need to give you a mic so people online can hear. Yeah, thanks.
I've just got one for Norlisha, and it's probably just a personal thing. But in the project, what was one of the main issues that you took away from your engagement with that research project at Malala? Yeah.
It could be a personal. Yeah. I don't think there was. I mean, there were lots of issues. But my biggest takeaway from that was when we first started, Tara and I and the clinicians who one of them's in the room facilitated a lot of the sessions. It was a lot of prep work. We put a lot into thought. We always asked the women at each activity what they wanted to do next. So we always prioritized what they wanted. And we always worried about sustainability of the project because, how are we going to take ourselves away from it and it still keep going? And the picture that was on the first slide was one of the last sessions we did, and that was completely run by the women. They picked the topics, they picked the facilitators, they did it in language, they picked the area, and Tara and I were just walking around kind of helping it, and that was like a big 360 moment. It was like, yes, like they've done it, they've got it, they want it. So I think that, and the growth in the women. We started with 4 women at the very beginning, and they were kind of like an elder auntie group, to then getting 29 to 30 people in a session, young women all bringing family members and wanting to learn. So I think just the breadth of their resilience and strength, but yeah, obviously sustainability is a big one. Tara.
I'm the other clinician who did some.
I was trying to be discreet.
I just want to speak to the sustainability because I also shared that concern, but perhaps to provide some reassurance. I go to Maningrida every month. I was there yesterday. I was speaking to Jessie Phillips. Those things are still happening. We're still doing the Women's Wednesdays at the Mama and Kika room. I'm still doing health, nutrition education, and Hamish the physio is still doing pool sessions. So the Menzies team made a huge impact in Maningrida, inspired so many of us to continue this work with or without additional funding. So sustainability. Yeah.
That's amazing. Thank you.
Thank you. That's so great to hear. That's why we're all here, isn't it? Does anyone have a question for Michelle and Waylon before we move on to the panel? Nothing online? Okay, you got off scot-free there, Michelle and Waylon, who we'll be happy to hear. Okay, we'll move on to the first of our panel discussions for today. So this panel is being chaired by Dr. Matthew Hare, who is a Senior Research Fellow here at Menzies within our Diabetes Partnership. He also works as an endocrinologist at Royal Darwin and Palmerston Hospital. I'm going to leave it to you from there, Matt. You can introduce your wonderful panel members. Thank you.
All right, if our esteemed panel members would like to come grab a seat, maybe do you want to have the 4 panel here maybe? And I'll sit to the side. You guys should be center of attention. That's good.
There you go. Oh, I popped it up.
Share that mic. You two have to share that. There's just a little switch on the side there. Don't know if you want to watch volume at all. That feels very loud, but is it too loud? No? Close to that speaker. So it's been such a fantastic morning already, and really looking forward to the rest of the day, where we're moving to slightly more discussion-based format, and it's a real privilege to be chairing this panel, and so grateful to each of the panelists for giving up their very busy schedules to be here. The discussion is going to be based around the theme of today. Feels very boomy. Where is the feedback in that speaker just there? So from research to change, the importance of partnerships. And I'll just introduce each of our panelists before we get going. So starting from your right, we have Val Wallace, who we met this morning. Just to remind you, Val identifies as a Gugubadun woman from the Valley of Lagoons in Yuin Country in Far North Queensland. And she also acknowledges her South Sea Islander, German, Chinese and European heritage. And yeah, Val has decades of experience working in health, policing and academia, with expertise in qualitative research, community engagement, Aboriginal and Torres Strait Islander protocols and research ethics. And she joined our diabetes team here at Menzies in early 2025 as a First Nations Senior Research Fellow, and continues in an academic role at JCU as well. Next, we have Dr. Leisa McCarthy. Leisa is a Warramungu woman from the Barkly region of the NT, and she's the Deputy Director of First Nations Engagement and Research Strategy here at Menzies. She's worked in Aboriginal health for more than 30 years and has held various leadership positions in policy, research and service delivery, including most recently as the CEO of Anyangini Health Service in Tennant Creek. Leisa started her career training as an Aboriginal health worker before completing undergraduate and postgraduate qualifications as a nutritionist, and specifically a public health nutritionist, and she previously worked at Menzies for more than a decade and completed her PhD here in 2017. So highly qualified. And next we have Sinon Cooney. Sinon has worked at Catherine West Health Board Aboriginal Corporation since 2007. So he's older than he looks. He's been part of the leadership team for many years before being appointed the CEO in 2019. He currently serves on the board of AMSANT, which is the Aboriginal Medical Services Alliance of the NT, and is a member of the NT Aboriginal Health Forum. He has a long-standing commitment to Aboriginal primary health care and has previously worked clinically as a remote area nurse. And finally, we have Dr. Liz Moore. Liz is a public health physician who's also got a substantial clinical experience in general practice in the community-controlled sector. She's been a public health medical officer at AMSANT for 17 years and is based in Alice Springs. Liz has had an active role in research and research translation at AMSANT during all of that time. And she's also been involved in our Diabetes Across the Life Course Northern Australia Partnership from its inception as a kind of key stakeholder and research investigator partner. So thank you so much for all being with us, and hopefully that kind of context of the expertise helps just kind of shape some of the answers you'll hear today. So the idea of the format, I've kind of prepped them a little bit with some potential questions, but I'm prone to going a little bit rogue. So, but feel free to jump in at any time with any reflections. But we'll start with you, Liz, if that's all right. You've been involved in this collaborative diabetes research program for many years now. It started as the NT Diabetes and Pregnancy Partnership back in 2011, and we've still got Louise up the back who has to leave for lunch shortly, but it's great to have you here, Louise. And I'd love to, obviously that's transformed over time between Diabetes Across the Life course, increasing work with youth onset type 2 diabetes as well. Could you talk to us a little about how critically important partnerships have been to this body of work?
I think, it wouldn't have been nearly wouldn't have really sustained itself without these partnerships. And I think, I guess from our perspective, the community controlled sector has had a really strong partnership from the get-go, which has kind of strengthened, and it's gone from, sort of AMSANT and the boards of AMSANT, and also services to CEOs to clinicians on the ground. And I think the first kind of research that came was a very long-term kind of study, but really importantly, I think, to engage, there was also a practical applied component, like a CQI health systems approach that brought clinicians from primary healthcare and specialist clinics together and really had an immediate effect rather than waiting, years for results. And so that was sort of set the tone, I think. But and I think clinicians on the ground, I've attended some of those meetings, really appreciated the chance to discuss all the issues and the health system barriers, and also the social and cultural determinants of health came up pretty early in those discussions. So that may have influenced the direction of the research. But that, I think from the get-go, that was really important.
For those who might be working in other areas or other research programs, what have you seen work? Like we use the word partnership a lot, but what does that actually mean? What?
I think sort of, well, I think that working really well with services. I mean, the two presentations we just had really demonstrated that the work that services did on the ground, and then researchers working with them to formalise and build on that and build the more evidence they were really great examples. I think what else? I think giving back, like with CPD and professional development, even like making this, it's a small thing, but making it's not really a small thing, but making this online so people from remote communities can join and listen. Those sort of things are really important. I think, listening to services and how that's broadened the youth diabetes, the work on prevention. I think, services and clinicians are really passionate about those things because it is so sad to see it getting worse. I think working with the sector on advocacy and for funding, not, the youth diabetes programs and diabetes and pregnancy programs are fantastic, but to scale them up, it's going to need government funding, and we've got to work together on how to make that happen. And also a broader advocacy about poverty and social and cultural determinants. We're not, again, going to get on top of the problem without changes in those areas, like the remote area allowance hasn't gone up for 20 years. It's woefully low, and things like, and food security is getting worse probably, and it may be getting better now because there's a bit of funding going into it. But I think working together, and I think that, like, I remember working with Louise on a submission we did into the diabetes inquiry, and we exchanged ideas and worked together, and I think those type of things are really important as well, to keep on doing that, because the research is going to make a difference. It's going to have to influence funding in the long term.
Thank you very much, Liz. Did any other panelists have any thoughts on some of those reflections on the diabetes partnership? I know, Lisa, you've been kind of involved pretty much from the get-go as well.
I think its longevity tells the story, basically, where there was that getting to know each other sort of time, and then starting to work together to build the trust. So that's what I saw in the partnership. And then the more that people were engaged, like specifically from the non-research sector, the more ownership people had, and that was really valuing those partnerships then. And then from that grew, amazing pieces of work, and where we actually have seen some improvement. And yes, we do still have a long way to go. But it is looking at where it started, but then what Norlisha just presented before was amazing, because now the women were coming forward, or the people are coming forward and saying this is what we want.
Yeah, fantastic. Now, next question is for you, Lisa. And so, as a nutritionist, researcher, policymaker, now executive, you've really had a 360-degree view of research in the health sector. Obviously, in research, we're seeking to improve understanding of critical health priorities and challenges, and to develop some innovative solutions. But we really want and need these learnings to have meaningful and sustainable benefit in the real world and sustained impact. In your experience, how do we do this? How do we best ensure that research actually leads to change?
Probably the very first thing is that it's the actual need is being addressed, and that's not the need from the researchers, it's the stakeholders' needs. So what are the health services, or what are the communities actually wanting to have researched? What are their priorities? So that's a very important place to start. It's also, again, about having the relationships and the partnerships as well, and valuing those partnerships, because they are very important. And it is a very, it's the way that you work with people. It's valuing all the different skill sets that are there, and the dynamics of that as well. And then how does that all come together to work together in developing or co-designing the piece of research that needs to happen? How is that then, implemented? But also, more importantly, how is that actually going to make a difference? So the impact is really where we should be measuring our success. But it's also about the sustainable impact as well. And we just heard about that and I think it was brilliant that the women are still meeting, out in Maningrida. And that's a big success story. So it's very important that the agendas are not about just the researchers going out. It is, what is the community wanting to? And, I can give an example. Menzies has been doing research in the Northern Territory now for what, 40 years? So as part of that, there has been the development of people out in the communities and understanding what research is and how research is undertaken. So people are now pushing back and saying, this is how we want to do it. This is what we mean when this is what good research looks like. So I'm really proud when I hear those stories from the communities.
Yeah, fantastic. Thank you. Sinon, jumping to you now. As a clinician and a health service executive, you've seen many a research project come and go. Do you think there is value for health services in partnering in research? And if so, what does a good partnership look like?
What a loaded question. Yeah, look, it would be hard for me to say no in this room. No, I do think there's a lot of value of partnering with health organisations in research, and yes, have seen lots of research come, some research go, and I guess the important part of it for us as a health service delivery organisation working with community is what stays, and I think that's sometimes the tension is what is the research outlook. The researcher or the research institute will do the research for a period of time and may move on to another research project, but the community still exists, the people in community who experience that. And we often hear in our sector from, especially from senior people, what happened to that. We contributed to that. We did a lot of work towards that, and we're not sure where it landed. And as people in the operational space, we can sometimes like point to, well, there was like this policy shift or there was this change in resourcing, whatever, but it's not always clearly visible to people on the ground in communities. And so I think really important part of the research paradigm, I guess, as far as working with community is what's left behind. I think the second part of your question is about what makes a good partnership. Yeah, I think openness, transparency, really important. Not promising what you can't deliver. I think sometimes that can be a real challenge as far as what is offered at the beginning of research is quite different by the end of the research, and the relationship and the partnership, because we all know how much work it takes. It's hard, especially when you're doing research and work in remote communities. It's expensive, it's time, energy, and people move on. We have a highly transient workforce, all of those sorts of things. So sometimes getting back to the ground to deliver the outcome of the research becomes almost a bridge too far. And I think the hard thing for us is we've made a commitment at the start with our boards, with our communities to go, this is why we recommend participating. And then if that's not delivered at the end, it can breach that trust. And I think similar to what you're saying, Leisa, communities are more and more taking ownership of what they expect and building research from the ground up. I think sustainability is really important. And again, similarly, I'm really happy to hear when there's research projects that result in sustainable outcomes. Because sometimes, like we're all dealing with, funding dynamics and whatnot, sometimes that can result in us moving on quicker than we need to. So where we can sustain it, build in mechanisms within the service delivery space so that work can continue beyond the research is really important.
Yeah, thanks, Sinon. I think it's also really important to note that in the health service sector, research is actually not part of their core business. So you have to be really, really mindful that the expectation on health services and how health services interact has to be really planned well and really done in partnership and very well supported. And I mean, there is the argument that if you want the health services to engage properly, then you need to have the capacity within. So it's about where is research taking the responsibility to then look at supporting positions or the work that's been undertaken in the health services.
Thank you. Val, I would love to hear from you. We've already had more than 40 years experience working in health academia and other related areas. When you think about how we go about research and how we conduct it, what has changed in that time, and what do you think the future should look like?
Good question. I think we've gone from, and I'm talking globally on research in general, not just about partnership. I think we've gone from research on our mob to research for our mob to research with our mob. And I think with our mob acknowledges that there is some pragmatic failure in cross-cultural communication, which is a good thing, because if we understand that, sometimes our mob don't understand what professionals and health professionals are saying and researchers are actually saying, and that goes both ways, because quite often researchers and health professionals don't understand what our mob are saying either. So we actually acknowledge that, and I think, that's part of building that partnership, and how important partnerships are. Is it's a bit like you really need a marriage made in heaven for it to actually work. So taking on board that, who you're working with, always know who your target audience is. That's really, really important. And like Leisa was saying, if you're working with health services, they don't get funded, they get funded for core business, which is actually providing the service for our mob. If you've got researchers coming in and not taking that on board and not actually having funding to fund that research in those organisations, you're taking that service away from our people. So actually, knowing who you're working with is really, really important. And building on partnership, and that connection with community is really important in building rapport. And sometimes one of the things that we don't do really well is allowing time to build those relationships with community and thinking it's just going to happen. Also need to take on board, who your research partners are, and although some of our mob might know community, might work within community, don't forget there's insider and outsider researchers, and that's really important. So it doesn't, just because we're Black doesn't necessarily mean that we're actually accepted by every community around the place. So we also need to build rapport with communities that we actually, aren't part of. And even if we are part of them, we actually need to take care of, who we are and where we fit within that community as well.
Fantastic. And I think we're not completely there yet. We talked about that journey from research being done on mob, for mob to with mob. What do you think are the key, when you look at the kind of health research landscape now, and not specifically the diabetes partnership, that you can give us strong feedback too, that's fine, from within. But when you look at health research and how it's going now, where do you see the main growth areas? What do you think we need to be focusing on moving forward?
Well, I think the fact that you have so many Indigenous staff, and you do take on the fact that, all those First Nations people bring, culture, are able to bring cultural knowledge to the workplace, to the research. And I think what's really great about the diabetes partnership is the fact that you guys do listen, and you do take on board what our mob are actually saying. And I think the Manangrita working out in Manangrita says it all, and that it is doable. Takes a lot of time. You book on a lot of issues, but it's like continuing to work and basically sticking with it.
Thanks, Val.
Yeah, I think as the partnership is like really working in the right direction. Yeah.
So maybe, Leisa, can I draw you out on that question a little bit too, just thinking about the future of how we can do better in this space in terms of partnerships and truly working meaningful collaboration on the right priorities. What does it look like in terms of our structures and our governance? What do we need to do?
It's probably how I'd like to see it is in layers or levels, depending on how you want to look at it. So to really make a big impact is basically that policy and funding shift that needs to happen. And let's go big, let's go national. So how does it actually get there? Because, in the Northern Territory, we always have that really bad health card, and it's almost like a badge of honour, which it shouldn't be. But yet there's no real, investment in there in terms of when you're looking at how is this research is actually influencing or impacting policy and funding change. It's really not there yet. So that's the piece that I think really needs to be worked on. And then let's just bring it to the Northern Territory level. It's also about how are we setting priorities within the Northern Territory. And it's not just about Northern Territory government setting this, the Aboriginal Community Control setting that. It's as a collective, how are we actually doing that, but also what are we committing in terms of resourcing that, and what are we committing in terms of how research influences that, or actually, and vice versa, how we're responding to what's the need. Then there's the local level or the community health service level. So where is that then trickling down to there and then trickling back up so that it's well supported, there's a very solid structure, and we can then work on how to address this issue. And we know that it's probably going to take another, 20 years until we actually start to see some dents and things improving. And as Liz just mentioned before, this is also bigger than just looking at health services. This is also about, the social determinants. So if you're looking at a group of people at the moment who are living in poverty, how are they going to get out of that, as an example? So where is research actually assisting with that? You're looking at the housing crisis that we have. Where is research assisting with that? And how is that impacting policy?
Thank you. Liz, maybe can I ask you about your thoughts on how we in the room as researchers, clinicians, people working in policy and things, how do we agitate for change? And we're talking about the need for sustainable investment at a federal level to set priorities for research and to invest in long-term relationships so we can have kind of effective research addressing the right issues, including social determinants. How do we raise that? How do we influence policy and leverage our voices?
I suppose by doing research that is going to show the funders that if they don't do this, things are just going to be more expensive in the long term, and there's going to be more human suffering. I suppose that, sometimes I found it a bit frustrating that there's not much research showing that if you don't invest in housing, you're going to get worse outcomes. I think that research is, I'm not an expert in that, but I think it's reasonably hard to do. And it, probably clinical trials and things like that are kind of easier in a way. I think working together, as Leisa just said, with government, the community controls sector, but also with the closer gap principles about community control and the importance of Aboriginal leadership always in mind. I think it's difficult. I think ACHISs do need more capacity around research, and if we're going to engage properly in priority setting, the whole funding system of research needs to change because it's so short term, and often, funding grants come around, in November when the boards are all in recess, and there's not much funding for ACHISs to think about what their priorities are and to work with researchers on those. And for the sector, there's not that type of funding. It's all coming top down from the government, as far as I can see, or research institutions. Well, I don't really know how that system works, but it doesn't seem to come from the ground up anyway.
Yeah, I mean, a lot of the funding calls are quite narrow or focused on particular disease entities, and we're kind of quite reactive and opportunistic when something comes around that seems relevant. I think there's been some good changes, and there've been people from the NT who've been involved in some Commonwealth panels around the MRFF, particularly with some kind of raising different priority areas and trying to draw out the length of grants to recognise the time that it takes to do meaningful work in First Nations communities. But yeah, there's still a lot more that needs to be done, isn't there? We've got 5 minutes left.
Anna. So this next session is really to learn about some of the PhD work and highlights from Dr. Anna McClean and Dr. Diana MacKay that graduated a couple of months ago. Their PhDs were based within the partnership and doing work in the Northern Territory and also in Far North Queensland. So Dr. Anna McClean, for those of you who don't know, is the clinical lead of the Diabetes in Pregnancy Service in Cairns. She's originally from Adelaide, but's been working in Cairns now for over 20 years. Anna undertook her PhD with us, focusing on improving management for women in diabetes in pregnancy in Far North Queensland, and continues to work with us in the partnership, really providing key leadership to our projects in the Far North Queensland region. I'll hand over to you now, Anna.
Thank you. Can you see my slides and can you hear me?
Yep, we can. Thanks, Anna.
Fantastic. Oh, thank you very much for asking me to talk. So this is going to be some highlights from my PhD. Exciting times. Before I start, I'd like to acknowledge the traditional owners of the Cairns people, the Gimmerwee people and the Jabberkai people, and all the other traditional owners around the country, and pay my respects to elders past, present, and emerging. So this was my PhD thesis that went in last year. And this is really a description of the last 6 years of my life, the PhD journey. So this idea of diabetes in pregnancy in Far North Queensland, we've been working on diabetes in pregnancy up here for a very long time. We started to become partners with Menzies in about 2015, which is actually 10 years ago now, which is quite a long time. And we started with some stakeholder engagement and some ethics, and created the Diabetes in Pregnancy Clinical Register for Far North Queensland in 2016. And then my PhD really involved these three main components, which was the models of care formative work, so sort of like the baseline, what we're doing in Cairns at the start. And then Diana really ran with it and took over the interim and the final evaluation, which she will talk to you more about. So we tried to improve and enhance our models of care. And then we started an interventional study looking at flash glucose monitoring for women with type 2 diabetes in pregnancy. And then there was another small study in the middle of that, which was an ultrasound study. But the work doesn't stop there. So we've also tried to enhance our models of care using a few other approaches, including the Mother app, which we're now using for women with GDM. We've got an electronic medical record dashboard. We've got some postpartum work with a new clinic and being involved with the co-design postpartum project with Menzies. And then this year, we're really trying hard to get a sustainable electronic extractable diabetes in pregnancy clinical register. So we talk about partnerships a lot today. My 11-year-old told me that collabs are really common all around the world with famous people and famous brands. So we're not the first to do this. And I would say that if Menzies was the Nike of First Nations health research in Australia, I would say that Queensland Health is really the chunky dunky Ben and Jerry's, but you know, we're learning. But it's not just Queensland Health. We've partnered with everybody we can think of up here, including Gurani, Mamu, Witrapura and Apuna Pima, the Torres and Cape Health Council. And then, as you know, the Northern Australia Partnership is partners with many different organisations around Australia, which is just fantastic and very inspiring. This slide I stole from Diana, to be honest, and it just tells us what on the ground does it mean. So what did we actually implement as part of improved models of care? And so we have the register, we've started to do postpartum recall lists and reminders. We've looked at where do the hospital discharge summaries actually go? How does the nurse navigator role fit in with diabetes in pregnancy? We've done lots of education, resources, newsletters, engagement with stakeholders and reference groups. And we've looked at our guidelines, our policies and our procedures. We've tried to improve our referral pathways. So quite a lot of work which is clinically relevant. One of those things was doing educational talks and workshops, and these are just a list of some of the ones that I have done anyway in the local, the regional, national and international meetings and conferences. This was over the last few years. How else did we disseminate our findings? Well, we published lots of articles, which is really fun. And I think the partnership is just extraordinary. If you look on the website under publications, there are just so many publications coming out of this group, which is really, really fantastic. So I'm just going to highlight a couple of things. So one of the publications that we did was looking at the growth of babies, looking at their antenatal ultrasounds and the association with neonatal adverse outcomes. And the problem with this was that there wasn't just a linear relationship. As the babies are bigger, their outcomes are worse. In fact, it's a U-shaped curve. And what this article kind of highlighted was we need to know more about what percentile is actually a small baby when women have got diabetes. And the ones who have small babies have actually quite high neonatal adverse outcomes. And this is relevant particularly for women with type 2 diabetes and women who are on metformin, because there's a sort of a theoretical question about metformin and small babies. One of the highlights for me was that one of our articles was chosen for the ATTD yearbook. So ATTD is an international meeting which is Advanced Technologies and Treatments for Diabetes. And they look at about 5,000 articles and they choose the top 10. And our study was chosen in that top 10 last year as an important milestone article. Another highlight was writing with Professor Louise Maple-Brown and Professor Helen Murphy. So Helen Murphy's done so much work in the UK on diabetes and pregnancy. She's a real guru in this area, and I was very, very fortunate to write an article with her, or a couple of articles actually, with her and Louise, and that's us having dinner. So the article that was shown in the yearbook was the results of our feasibility trial, the feasibility and acceptability of flash glucose monitoring or intermittently scanned CGM for women with type 2 diabetes and pregnancy. And basically what we did is we took this kind of blood glucose records and made it into something a bit more 21st century using Libres. So flash glucose monitoring is now quite widely used, but at the time it was pretty new for women with type 2. And so CGM's been used in type 1 diabetes for a long time, but it's relatively new to the type 2 space. And basically the benefit of it is that you don't have to prick your finger. You can just scan the sensor and see what your sugar is at any time of the day. And you get a nice pretty graph like I showed you, which tells us what your sugars have been doing. And when we started this project, there were no articles, there was no literature at all in the world about using these devices for First Nations women with any type of diabetes, and nothing about rural and remote health, nothing about using it for type 2 in pregnancy. There was literally a handful of patients included in other studies with type 1 just for safety, basically. So we were the first in the world to be using this for women with type 2, and so we aimed to look at the feasibility and acceptability. We really wanted to do a randomized controlled trial, but we didn't have enough money, so instead we did a pilot, and we looked at the feasibility, and then we looked at the actual glucose levels and whether there were associations with neonatal outcomes. So we had about 78 eligible women over a couple of years. After excluding those who were referred too late, about a fifth of people were actually referred after 30 weeks, which highlighted a big gap in our model of care, actually. 57 were allocated to using a flash monitor, and again, about a fifth of women couldn't use it because of rashes or side effects, or it kept falling out, or it wasn't accurate enough. And so we learned a lot from just seeing what happened with people. And we ended up with 45 women who used it successfully throughout pregnancy, and then they all completed a questionnaire. And the summary really was that they loved it. They much preferred to use a CGM rather than prick their finger 4 times a day. And 94% of women would recommend it to other women. They found it pretty worthwhile. But there were a subset of people who it didn't work for, and the late referrals was a problem, discontinuation was a problem, and variable and intermittent use was a bit of an issue. So these things are really important and have informed other trials that are now looking at the efficacy in type 2 diabetes. And with the metrics, so we looked at the levels of sugars and just found, some interesting things. So neonatal hypoglycemia was associated with blood sugar levels all throughout the pregnancy. So the higher the sugars, the more likely the baby was to have a neonatal hypoglycemic episode requiring intravenous glucose. But for gestational age, in fact, it's the early pregnancy sugars that are most important. The later ones didn't really make much of a difference, which means it's a bit late by the time you intervene if it's in the 3rd trimester. So this is really important that we get to see people early and get people's sugars down very early in the pregnancy to improve the outcomes for babies. The other thing we found was that if you didn't use the sensor, your sugars didn't really change much, but for those who used it a lot, their sugars got better throughout the pregnancy. So where does this leave us? Well, one thing that I really have found through all of this is that technology is here, whether you like it or not. So we really need to integrate this into our models of care. We have to make sure that people have access to diabetes educator expertise. We have to make sure that there is equitable access to technology and that people can afford it and that health centres can provide it, and look at the costing and where are you going to get your sensors from and how can that be supported. You need culturally safe, linguistically appropriate education. And this is something that we are continually working on. We still need big randomized controlled trials to work out if CGM is actually going to improve outcomes in type 2 diabetes in pregnancy. And we still don't really know, when we're using these sensors, what are our targets exactly. So there's quite a lot of more work needs to be done in this space. And I'd just like to echo what Louise Maple-Brown has written in, if you haven't read it, this really good articles in the Lancet Global Health a few years ago about empowering Indigenous communities worldwide to be at the centre of design of future research. And on that note, I'd really love to thank my 2 supervisors, Dr. Liz Barr and Professor Louise Maple-Brown, who are both extraordinarily patient, and they've just both taught me so much. And I'd like to thank the Diabetes Centre in Cairns for all their hard work and support, and all the women who participated in the studies. Thank you very much.
Thanks very much, Anna. We might take just one question. We're slightly over, but it's be really great to open to anyone that might like to send a question your way. And can I just remind people online, if you could just make sure you're on mute when you're not asking a question. Anyone? I've got a question. Okay, well, we need to get you a microphone. Just hold it. Thanks. Or a box.
Box, is
Does
there?
it work?
Yep.
I'm not sure about throwing it.
Thank you. Anna, hi, it's Veronica from Cairns. Just really enjoyed seeing your full presentation for the first time. Amazing data and amazing timeline, far out. That's just so much hard work. I just wondered, is there anything that we can do from the ground up to invite more, I guess, high-level participation in getting funding for these DREAMS RCTs that are required to, I guess, stamp that evidence base in our future for both GDM and type 2 diabetes in pregnancy? What are your thoughts on that?
Thanks, Veronica. Yeah, I think there is an RCT going with Helen Murphy's group in the UK at the moment, and that will give us a lot of the answers. So I don't know that we necessarily need to replicate that right now. So that's already underway, which is great. But there still could be so much more work in this space, and getting funding for these things is a challenge. But Matt is doing a study which will be looking at use of CGM in a particular community, and there will probably be really useful at nutting out some of those issues as well in terms of models of care and so forth. So I'm looking forward to that project.
Thank you very much.
Great, thank you, Anna. I will invite Diana to come back up to present on her PhD findings. Thanks, Diana.
Thanks, Renee. I'm mindful of standing between everyone and lunch, so I'll try to be relatively succinct. Well, good. Thanks, AG. All right, so this slide is really just to set the context, I guess, for within which my PhD was situated. And this, you can see, and I know these things won't be news to people in the room, that there are lots of barriers to providing care for women with diabetes in pregnancy in Northern Australia. And even for those of you who aren't working in the pregnancy space, I know these barriers are going to look familiar for providing care for young people with type 2 diabetes as well. But this really provided the rationale for the study within which my PhD was situated. And that was the Diabetes in Pregnancy Health System study, which the overall study was led by Professor Louise Maple-Brown and funded by a Global Alliance of Chronic Diseases, an HMRC grant, implemented between 2016 and 2019, with implementation occurring across the Northern Territory and in Far North Queensland, aiming to improve the systems of care for women with diabetes in pregnancy. And the components of this study included embedding the Diabetes in Pregnancy Clinical Register in the Northern Territory, as well as establishing it in Far North Queensland, as it was new there as part of this study. Anna mentioned the recalls and reminders which have been developed and embedded in primary care health records, as well as improving hospital discharge summaries, providing clinician education and developing some culturally appropriate education resources, the formation of various stakeholder engagement mechanisms which continue to serve our partnership to this day, and ensuring that relevant guidelines and procedures were up to date and in line with existing evidence and promoted through clinical champions. So my PhD involved evaluating this large study with the key areas of interest being around what impact has the study had on systems of care, and we think there about things like, do clinicians use guidelines, how does communication happen between services, what was the impact on care provided, such as whether women were or were not having their diabetes testing, the impact on maternal and neonatal outcomes, and then also looking at process measures, by which we mean how was the study actually implemented. And in order to look at all of those things, we use data from the clinical registers, which includes antenatal data and birth outcome data in the Northern Territory, and also some postpartum data in Far North Queensland. Because we didn't have postpartum outcome data in the Northern Territory, we're very grateful to receive de-identified data from Danila Dilba Health Service and Central Australian Aboriginal Congress, as well as from NT government primary care clinics. And then we had qualitative interview data from health professionals, who, as well as other stakeholders, and from the implementation team. And health professionals were also invited to participate in surveys both prior to and at the end of the study. So if we look first at what health professionals had to say, so about 2/3 of survey respondents said that as a result of the partnership's work, they had made changes to their own practice. And when we delved into those changes in the interviews, the kinds of things people said were that they were referring to specialists earlier in pregnancy and more frequently. There was an increasing focus on postpartum follow-up, recognising that that's a really important opportunity to improve the health of women for any future pregnancy. And there was more encouragement for women in diabetes self-management, with a shift away from a more paternalistic model of care. Clinicians also said they were using the 75-gram oral glucose tolerance test more frequently at the end of the study period for screening in the first trimester. Now, I know that there have been recent changes to screening recommendations, but we have to bear in mind that was the first line recommended screening test during the study period. And clinicians also said that they had more confidence in looking after women both during and after their pregnancies. When asked about the impact on health systems, clinicians said that the partnership's work had led to the establishment of a network of health professionals and services across the NT and Far North Queensland where they could access support. The clinical registers were seen as important in providing data both for quality improvements, identifying areas where more work was needed, as well as in providing evidence which people could then show to their services to justify allocating more resources to look after women with diabetes in pregnancy. So when we looked at the care provided to women, we essentially compared the care prior to and then after the intervention using the clinical register data and that primary care data that I've mentioned. And we were looking at a whole range of things, including diabetes checks and other indicators around weight, breastfeeding, smoking, and contraception. And on this slide, we're looking at the results for first trimester diabetes screening for women who have risk factors. So these are women where it would be recommended that they should have screening early in their pregnancy. And currently on the slide is the data for the Northern Territory with First Nations women on the left and non-First Nations on the right. And the highlighted blue bars there show that there was an increase in overall first trimester diabetes screening for First Nations women, including increases in the use of both the oral glucose tolerance test and the HbA1c, being at this time the first and second line recommended screening tests. And for non-First Nations women, there was no change in overall screening rates, but there was an increase in use of the oral glucose tolerance test. Whereas in Far North Queensland, for factors which we don't really know why, we did actually see a decrease in first trimester testing in these women. When we looked at weight, there was actually a decrease in weight being documented over the study period, both in the NT and Far North Queensland for women with gestational diabetes or overt diabetes in pregnancy. And in the Northern Territory, weight and body mass index increased over the study period, while there wasn't a significant change in weight in Far North Queensland. If we turn to postpartum care, so the results on the screen are from the Northern Territory, and there was an improvement in postpartum diabetes checks being completed after the study period. And we similarly did see an improvement in Far North Queensland as well. And in Northern Territory, we also saw an increase in women using contraception postpartum. In terms of other postpartum indicators, there was no change to measures associated with weight. And while breastfeeding and smoking at the end of the study were more likely to be discussed, or at least there be documentation that they were discussed with the woman, there were no change in breastfeeding or smoking rates, although noting that breastfeeding was coming from a high baseline. And when we looked at birth outcomes, which we did using clinical register data in the Northern Territory, so this slide is showing the results for neonatal hypoglycemia, or for the babies of the mum having low blood sugars in that early time after birth, with the non-Indigenous women on the left and First Nations women on the right. And the blue bars are for gestational diabetes, the red bars for overt diabetes in pregnancy, and the green bar for women with pre-existing type 2 diabetes. So you can see for the non-Indigenous women, there was a decrease in the rates of neonatal hypoglycemia over the study period, whereas there was no change for First Nations women. And we similarly saw improvements in neonatal jaundice for non-First Nations women and in rates of caesarean section for non-First Nations women, but no improvements in outcomes for First Nations women. And for First Nations women with gestational diabetes, while it didn't reach statistical significance, there was a trend for increasing macrosomia if the mothers had gestational diabetes. And one of the other key findings for First Nations women was that in all diabetes types, we saw a decrease in rates of exclusive breastfeeding at hospital discharge, which I think is a really important area for us to be looking at, given what Brandy mentioned this morning with what we know about the importance of that for health outcomes for the children and also for the mother. So essentially, to summarise, we could see that with the work of the partnership, there were improvements in the care provided to women with diabetes in pregnancy. However, that improvement in care didn't actually translate to improvement in outcomes for First Nations women. So we know that the project, I guess, was limited in scope in being a health systems project. And I think that really highlights that if we want to improve outcomes for women and their babies, we need to not just work at the health system, acknowledging that that is really important, but be looking beyond the health system too, which I think is where some of the more current work of the partnership, working with communities, with peers, that kind of work is important, as well as what Liz was mentioning earlier on the panel, actually, that advocacy work to create change at a government and policy level. So some of the other key issues were weight being a really important thing for us to focus on as going really backwards with that. And we need to do more to understand why breastfeeding is decreasing in First Nations women. While this is just one, I guess, data point, we also know from some of our qualitative research, women are telling us, as well as community members, about decreases in breastfeeding and, I guess, decrease in duration of breastfeeding as well. So it's important for us to understand the factors behind that. I think I'll leave it there just to thank, obviously, so many people and services were involved. Renee was my primary supervisor, along with Jackie Boyle, also he was on my supervisory panel, and Louise, and then Sandra Campbell, who is an amazing maternal health First Nations researcher in Cairns. Thanks.
Thank you so much, Diana. That's a very impressive body of work for a PhD, I'd have to say. Well done. Now, I would love to celebrate your achievements of your PhD for those of us who have done a PhD. As Anna so clearly and eloquently described, it is a journey. So we'd just like to give you some flowers. And Anna, there's also some flowers for you at the Cairns Diabetes Centre. So Diana, congratulations. We could ask one question if we had a burning one for Diana. Otherwise, as she said, lunch is waiting. I'm just going to quickly get through. We have yes.